All right, well, why don't we go ahead and get started and people can join us. I'm very happy to welcome Marilyn Ahun, who is a postdoctoral fellow here in our department, and we're very excited to hear about her work with UNICEF. And I will let you take it away. We have a hybrid talk today, so some of us are here in person, some of us are here on Zoom. I'll open my computer in case folks on Zoom want to ask clarifying questions, but we'll leave the rest of the questions until the end. And I will let Marilyn take it away. Excited to hear from you. Thank you for joining us.
Thank you. All right, well, good afternoon, everyone. Thank you so much for joining today. I will be presenting some work that I did with colleagues last year, reviewing the implementation and evaluation of the Care for Child Development program that was developed by UNICEF and the WHO. So my talk today will first focus on giving a general background on the nurturing care framework, which really informed the development, or the concept of the nurturing care framework informed the development of Care for Child Development and how it's currently constructed. And I'll go over a little bit about the history of how this package was developed. I'll then present the results from a systematic desk review that we did, as well as some key informant interviews with individuals who have in-depth experience working with the package in different places around the world. And then I'll finally go on to talk about some key take-home messages and lessons learned, not only in terms of this package, but also in terms of parenting packages more broadly and how we can advance the field. And so the work that I'll be presenting today has recently been published in Frontiers in Public Health with colleagues from the department, such as Aisha Yousafzai, as well as some colleagues from the Department of Psychology at McGill. So I'm more than happy to answer questions afterwards, but there's also a lot more detail provided in the publication. So when we talk about early childhood development, we're really talking about age-related increases in different domains such as cognitive, socio-emotional, motor, and language skills. And the nurturing care framework was designed to encapsulate different aspects of the home environment that can influence child development. And so these different dimensions include ensuring that children have good health, adequate nutrition, opportunities for early learning, safety and security, and responsive caregiving, which is defined as providing timely and developmentally appropriate responses to children's actions. And so a lot of evidence has shown that interventions that target one or more aspects of the nurturing care framework do lead to improvements in early childhood development outcomes, and particularly interventions that target the opportunities for learning and responsive caregiving components. However, there still exists quite significant gaps in the literature in understanding how these programs are implemented, the different processes that are used, and how to scale up these packages so that we're working to improve early child development at a population scale. And so one of these packages is the Care for Child Development package, which was developed by UNICEF and WHO to promote nurturing care for young children between birth and 5 years old through integration in existing services, and has been primarily targeted towards services in the health sector. And so just to give you a little bit of background as to how this program came to be, in the mid-90s, there was a creation of the Integrated Management of Childhood Illness, or IMCI strategy, to address child health and well-being. And this was really targeted at decreasing levels of childhood mortality. But over time, we came to realize that these children who are now surviving that were surviving key risk factors in the early childhood period weren't necessarily thriving. So they were living, but they were suffering from issues such as stunting and poverty that were significantly impacting their developmental potential. And so in 1999, the WHO mandated a review of effective nutrition and ECD interventions to address gaps in the IMCI. And this led to the launch of the first version of CCD, and it was implemented through the IMCI module on child nutrition. And so the first evaluation of CCD occurred soon after in 2006, and this was led by Ilgi Ertem in Turkey. As the program was being implemented and UNICEF and WHO were receiving feedback on the program, this led to a launch of the second version of CCD, which was now a completely separate module from the IMCI, and the content was expanded to include responsive caregiving. Again, based on different implementations and feedback, A third version was created to include counseling, so having frontline workers counsel parents on how to engage in responsive interactions with their children and to improve child health and growth. And CCD was also integrated into healthcare workers' home visits. And in 2017, there was a review and a white paper that looked at CCD implementation and evaluation up until that point. And so overall, the current package of CCD, which was last changed in 2014, consists of 2 age-specific recommendations for caregivers to responsibly play and communicate with their children. And so UNICEF and WHO provide open source materials, including a participant manual, a guide for clinical practice, and a framework for monitoring and evaluation. And so the manual includes counseling cards, which has specific activities, play and communication activities that caregivers can engage in with their children at different developmental ages. And it also has a checklist for frontline workers to identify the practices that caregivers are engaging in. So this is an example of the overall objectives highlighted in the manual for the CCD program. And this is an example of a counseling card. So we can see here if this works. There we go. So for newborn birth up to 1 week, there's suggestions of how to play and communicate with children. And then for different intervals going on, there are examples of how caregivers can responsibly engage with their children as a means of improving their developmental outcomes. And there are 2 prior reports that have summarized the implementation and evaluation of CCD. And so both of these were primarily based on interviews with UNICEF workers across the world. And they identified that CCD had been implemented in 23 countries, primarily in the global south, but it had only been evaluated in 3 sites. And this was in China, Pakistan, and in India. And CCD-based programs were found to significantly improve nurture and care practices as well as caregiver outcomes. However, these reviews identified that few studies reported information on how CCD had been implemented. And so there was little data on how frontline workers were being trained, how they were being supervised, how the implementation process was being monitored over time. And there was also information lacking on the scale and sustainability of CCD in the long term. So given all of this general background, we wanted to provide a systematic review of the implementation and evaluation of CCD by summarizing peer-reviewed gray literature and key informant reports of CCD implementation, describing the extent to which it had been integrated into existing government services, and identifying key barriers and facilitators to CCD implementation. So we primarily identified articles through PubMed and Global Health Ovid, as well as through conversations with staff from UNICEF and WHQ, as well as with ECD experts. And the sole inclusion criteria was that the article or document reports data either on the implementation or evaluation of a specific program that had been informed by or based on CCD. And I'll talk a little bit about this distinction later on. And then we extracted data based on the CARE and CONSORT guidelines. In terms of the key informant interviews, we primarily spoke to individuals at UNICEF, HQ, and ECD experts to identify individuals who would be key to talk to for these interviews. And so we particularly included individuals who have been directly involved in the implementation or evaluation of CCD, and this involved either training frontline workers, monitoring their implementation, or supervising them. Then we also wanted to talk to individuals who had considered using CCD package, but then chose not to try to understand what led to their choices of not using CCD. Then we also spoke to a couple of individuals who've been involved more at the higher level stage, so in developing the package, but not necessarily in implementing or evaluating it. And we developed semi-structured topic guides for these interviews and conducted them virtually from January to March of last year. So overall, we identified 55 documents describing the training, implementation, or evaluation of CCD in approximately 58 services across 30 services and countries. And all of these were low and or middle income countries. So we primarily identified articles, peer-reviewed articles, of course, from the literature search, but then through conversations with our key informants and staff from UNICEF and WHO, we identified additional reports describing quite a few services that had been implemented. So as I go through the results, I'm first going to focus on the different settings in which CCD has been implemented in and who the beneficiaries have been. I'll then go on to talk about the content and structure of services, the characteristics of delivery agents or frontline workers, and then finally talking about the evaluation of its impact on child and caregiver outcomes. So this map showcases the different countries in which CCD has been implemented to date, and the different colors indicate the amount of information we have about these different implementations. So in red, we have peer-reviewed preprint or gray literature reports describing the implementation or evaluation of CCD, and these are the countries for which I'll be presenting data today. In blue, we have countries where key informants mentioned that CCD is being implemented, but there are no written reports as of the time we did this review describing this work. And then in yellow, we have countries where UNICEF records that CCD has been implemented, but again, there are no written reports. I do want to highlight though that at the time of our review, there were no written reports of the Criança Feliz program in Brazil, which does incorporate aspects of CCD, but they have since published some articles. So hopefully in a future review, we'll be able to learn some key lessons from that implementation. In terms of beneficiaries, the primary beneficiaries of most programs were children between the ages of 0 to 5 years and their primary caregivers, which in about 99% of cases was their mother. But we did find that most programs particularly focused on the birth to 3-year age range. So it seems that children of ages 4 and 5 are not necessarily benefiting from CCD programs. And this is likely because they fall in that gap between the health sector, being involved in the health sector versus the education sector through preschools. Beneficiaries primarily came from disadvantaged backgrounds, and there was some service that specifically targeted vulnerable groups. So these included children with developmental delays or disabilities, children of HIV positive mothers, children born with low birth weight, and children of incarcerated mothers. And so this last group was a particularly innovative program in certain prisons in Paraguay where mothers are allowed to live with their children. There were group-based services that incorporated aspects of CCD. Services were primarily provided in rural areas, and a handful of reports described delivering CCD in specific contexts. And so there has been some implementation of CCD in conflict-affected areas in Syria. During Hurricane Irma in Belize and Anguilla, emergency response workers who were taking care of young children incorporated those 2 key recommendations to engage in responsive play and communication activities. And as well, during the Zika epidemic, CCD was integrated into part of that health service response. And additionally, there were some reports that described adaptations to service delivery for the COVID-19 context. And so this primarily consisted of shifting services to a virtual format or holding group sessions outdoors in order to ensure that people could still meet while we were dealing with the pandemic. In addition to primary caregivers, about a third of programs also included other caregivers, and this was mostly fathers and grandmothers. And I will note that it was mostly more recent interventions that had this inclusion of another caregiver. So it really reflects the general trend that we're seeing in considering other caregivers beyond the mother in terms of their role for supporting early childhood development. We also had some reports that reported on caregivers' perception of CCD programs. So how did they feel about it? What did they like? What did they not like? And overall, they found that caregivers enjoyed receiving these services and that they found them helpful in improving the ways in which they engage with their children. However, some caregivers also highlighted key issues, namely the clarification of the service's purpose. And this was primarily in the case where there was one health visitor who was conducting lots of different tasks and lots of different visits with a caregiver. And so the caregivers weren't always sure, well, how is this different from that other service that you're providing for me? What's going on here? Why do I need this particular separate service? There was also, caregivers also highlighted that there was a need for more explicit and repetitive messages on why certain activities are important for ECD. And so even though the frontline workers were teaching or counseling parents on these activities, it wasn't always clear, well, why do I need to talk to my child, when my child is in my belly? What's the point of that? How is that going to help my child do better at school? And so having that link of here's what you do and here's why it's helpful for your child, there was more of a need for that in the process of implementing CCD. In terms of the content and structure, there was quite a lot of variation in the extent to which it incorporated, a given service incorporated CCD. And so earlier I talked about CCD-based versus CCD-informed services. And this distinction was really based on the extent to which a service relied on the CCD package to inform its structure. So CCD based refers to services that used the participant manual and the counseling cards as the sole form of implementing the program. Whereas on the CCD informed side, we have programs that consulted the CCD package, but then looked at other existing packages to better, to then construct a curriculum that they then implemented. So for example, in Turkey, which was the first evaluation of the CCD program, pediatricians used the CCD checklist and the counseling cards to recommend play and communication activities. So this particular service consisted of 2 15-minute clinic visits, and it really just consisted of walking through the counseling card with caregivers. But in Syria, for example, the CCD was the primary package used, and so the service was constructed around the counseling card, but the implementers found that there was some information missing, and so they supplemented it with information from the CDC's ECD materials. And then finally, on the last side of a truly CCD informed service, we have this intervention that was implemented by Walkers et al. In Zambia, where CCD was just one of many different sources that they used to develop a curriculum. And I do want to highlight here that most programs on the CCD informed side were more likely to have a structured curriculum that frontline workers would use for engaging with caregivers. So if you remember the counseling card, it really consisted of simple and short messages on here's how you can play with your child, here's how you can communicate. But there isn't a clear structure of, well, how often should I be talking to parents? What are some other things that I can be talking to them about beyond these different activities? So CCD informed programs are more likely to take the time to develop a more structured curriculum using CCD as well as other resources. And the majority of the programs that we reviewed were CCD based, and they used varying delivery modalities and intensities. So again, within the participant manual, there's not much clear guidance of when CCD should be implemented and by who. Because it was initially integrated into the IMCI, it's generally been administered by health visitors within a clinic setting, but that's not always the case. So in our review, we found that most studies used a combination, and in most cases, it was a combination of home visits and group sessions. But there are quite a few studies that also used clinic visits. And interestingly, there were 3 studies that used play boxes. So this is where they would set up a box of toys and books and different play materials in a clinic setting where there was no individual talking to caregivers, but they made these materials available for children to engage with as they were waiting to see for a well child or sick child visit at the clinic. And in terms of intensity, there was a lot of variation here. So going from 1 5-minute session to 40 fortnightly sessions over 2 years. So as you can see here, it's really hard to say how CCD is being implemented where there's such a gross variation in how often these contacts are happening, over what period of time. And so that made it a bit harder for us to clearly understand, well, what is the key ingredient of CCD and how does that key ingredient then lead to improvements in child and caregiver outcomes? What we also found was that there were 3 broad types of adaptations to the content of CCD. This primarily consisted of translating CCD materials. This was sort of the simplest adaptation to a given context, was translating the counseling cards into local languages. The next level of adaptation consisted of more substantive modifications to CCD materials. And so adding content on mental health, for example, or including more structured play and communication activities to sort of further build out the information that was being shared with caregivers. And then finally, there was more qualitative work in most cases to adapt CCD materials for the local context. So this included including local games or local songs that children engage in. There were also quite a few interesting adaptations made for vulnerable children. And so in Malawi, for example, they adapted the activities for children who are visually impaired. So these activities primarily focus on sound, on touch, and other senses, so that caregivers with visually impaired children could still play with their children, but without solely relying on sight as a means of doing so. And in terms of how CCD was delivered with other existing packages, 95% of reports didn't specify whether CCD was delivered as a standalone package or whether it was delivered alongside another package. So again, we're not clear, it's not clear what context within which caregivers are receiving this messaging. For the 5% of studies that did, CCD was mostly bundled with nutrition or health packages. And in one particular case where they just published the results in the Lancet Child and Adolescent Health, they had an implementation in Vietnam where CCD was delivered alongside the Thinking Healthy program. And at the same time of addressing ECD, they were also addressing maternal mental health. In terms of the delivery agents or frontline workers who were delivering CCD, most of them came from the health sector, but it was really nice to see that even though CCD started in the health sector, it's really been spread out into other sectors. And so we had daycare workers and kindergarten teachers also implementing CCD and incorporating it into the preschool environment. There were also a few social workers, and in some cases, members of the community such as mothers or community-based volunteers were trained to administer it. So it shows that there really is a variety in the type of frontline workers that can deliver this program. In terms of training, however, there was again a lot of variation. So it generally varied from 2 days to 3 weeks, with most studies training for 2 to 5 days, and the recommended number of days of training is 3. So there were some studies where frontline workers weren't receiving the necessary amount of training in order to implement this package. There were a variety of trainers used, and many countries used the train-the-trainer model. So you would have, for example, individuals from UNICEF or PATH who would train the administrators in a health center, for example, and then those administrators would train the frontline workers. And although this model does help to ensure that multiple people are being trained and that the frontline workers aren't the only individuals in the context who know how to use CCD. In the key informant interviews, one issue that came up was the fact that there wasn't much continuation. So there wasn't an evaluation of the training from for example, someone at UNICEF to the administrators, and then there wasn't an evaluation of, well, how well are those administrators then training the frontline workers? So there's kind of a loss of information as we go down the line of different individuals and groups of people being trained. And adding to this, there are a few countries that conducted pre and post training assessment of delivery agents' ECD knowledge and skills. So there really isn't much information of, well, how well do people know CCD? How well do people know how to implement it after the training? And this is a key issue when it comes to ensuring the sustainability of the program, because if we're sending individuals out there to say, okay, you've now been trained in CCD, but we don't know what that means, we don't know what criteria are being used to determine what it means to be trained in CCD, then it's really hard for us to say, well, this person is actually implementing CCD, which then of course makes it harder to evaluate the impact of the program. So that's something to keep in mind as we go on to discuss the evaluation of the program. In terms of integration, one good thing about CCD is that it has been integrated into services across a variety of different ministries in the health sector, education, and social and human development sectors. But few sources described how this is being done, and specifically how CCD is being integrated into the existing roles and responsibilities of delivery agents. And so if you remember earlier, I had mentioned that in terms of their feedback, some caregivers had said, well, you know, you're a health visitor you come here 4 times a week and you give me a different message each time. I don't understand what the difference is between these different services. Well, in some studies, they also interviewed delivery agents who said the same thing. You know, well, I've been trained in this new thing, but isn't it the exact same thing as this other thing that I'm doing? What's the difference? And there was also the issue of them feeling overburdened, that this was just another task being added to the long list of things that they already had to do. So this was an issue that wasn't always addressed or clearly reported within studies. In terms of the few studies that did report data on supervision, it suggests that on average, delivery agents are supervised about once a month, and there's a variety in the different supervisory strategies that are used. But I do want to emphasize that this was really a minority of studies. In most cases, we don't know how CCD agents are being supervised and what level of training the supervisors have to be able to provide helpful, constructive feedback to the frontline workers. Related to that, some sources mentioned that delivery agents' fidelity to CCD had been assessed, but again, we don't know how. The few studies that did say how they'd done it, there were some that used the CCD observation of providers counseling checklist, and then others sort of created their own systems. And so it's not really clear how CCD is being implemented and how we're able to compare fidelity across different contexts implementing it. I do want to highlight the Belize system though, because at a country level, they really work to create a monitoring and evaluation surveillance system for CCD as it's implemented in different districts across the country to ensure that there is some consistency in how we're comparing CCD services across the country. Finally, in terms of the evaluation, there were 19 out of 55 reports that reported evaluating CCD, and only 9 of them were RCTs. So all of these results should be taken with quite a large pinch of salt. So most reports focusing on child outcomes found small to moderate short-term impacts. And so in most cases, they were measuring impacts about 12 months after the program had been implemented. And the same for caregiver outcomes. About half of them found significant improvements in caregiver outcomes, but again, this was in the short term. There has been only one long-term evaluation of CCD, and this was Professor Yousafzai's work in Pakistan, and this looked at outcomes 2 years after the program had been implemented and found consistent improvements in children's cognitive outcomes as well as in parenting outcomes. And then in terms of the informant interviews, we separated out respondents' answers into 6 different themes. So first, trying to identify what the key definition of CCD is. Are people interpreting it in the same way? Are they using it in the same way? And then we went on to talk about the advantages and disadvantages of CCD, lessons learned in terms of barriers and facilitators to implementation, and how we can improve CCD for future generations. And this is a list of the different individuals that we interviewed. And so you see we interviewed individuals both in academic settings and in NGO settings. And we also tried to ensure that we were interviewing individuals who'd worked in different countries with the CCD program. So in terms of the definition, it was pretty clear and consistent across respondents that CCD was really focused on these 2 practical skills: responsive caregiving and playing and communicating with young children. And it was also clear that it was initially intended for health workers. So the goal of the program is to train health workers on how to counsel parents to better engage with their children. In terms of the justification, this was a theme that came out quite a bit. What motivated people to use CCD was this aspect that it had this UNICEF and WHO seal of approval on it. So really it was more about the branding of the program than the content itself. I didn't include the quote here, but for some of the individuals who didn't use CCD, one of the reasons why they didn't was because they felt that there was no core structure. They felt that they couldn't build out a consistent and clear program based on these 2 simple messages. In terms of the advantages, informants highlighted that it was flexible, simple, and easy to implement, and that it was key as a tool of highlighting the importance of responsive caregiving for promoting ECD. However, one key disadvantage that came out of it was this lack of structure. And so the assumption that you can just take CCD and give it to any frontline worker and say, well, here you go, use it, there isn't enough information. And especially when working with frontline workers who come from different backgrounds, who don't have any experience in ECD, some informants felt that there just wasn't enough structure in terms of the training, the supervision, and the monitoring to ensure that CCD could be implemented with fidelity. In terms of barriers to CCD implementation, this was primarily highlighted at the frontline delivery worker level. And so people highlighted that there was high turnover and heavy workloads in the workforce. In terms of the training process, there was lack of sufficient information on the why of ECD, of why should I be incorporating this into my work? Why is this work important? There was also issues of sustainability, as we know with a lot of different programs without funding. And in most of the research that informed this review, CCD was funded by external sources. So there isn't much government support or funding for CCD programs. And as I highlighted before, there were difficulties with the cascade training model and ensuring that there was consistency in how the training was being conducted, going through the different stages of individuals who were trained. In terms of facilitators, on the other hand, contexts in which there was government buy-in and support really helped to ensure that CCD could be integrated into existing services and even integrated into policies. having community champions and advocates, individuals who understood the importance of early childhood development and saw how CCD could help to improve that, really helped to facilitate its implementation across different contexts. When asked what advice they would give individuals who wanted to implement CCD, informants highlighted the need for conducting a job analysis. So really trying to understand what is the current role of the frontline worker you want to work with, and how can CCD be incorporated into those current practices was a really key point. In addition to that, there was also the contextualization, trying to understand what services already exist in this context, how are they similar or dissimilar from CCD, and how can CCD be used, perhaps not as a replacement, but as a way to support existing services. And I think this was something that would have been appreciated both in terms of the frontline workers, but also in terms of parents, to feel that there was some consistency in the different services that they were receiving. Oh, sorry, going backwards. And then finally, in terms of their advice to UNICEF and WHO in terms of how to improve CCD moving forward, informants highlighted the importance of clarifying what the package is intended to be and what it's not, so that anyone, because it's open source, any individual can pick up CCD and use it. But having more clarity on how it's supposed to be used, some informants felt would help to improve its future implementation. There was also a lot of talk and comment about facilitating communication between the different individuals conducting CCD, so that they could learn from one another's mistakes, from each other's strengths, and really have a network or a forum to facilitate this communication. So in terms of the key take-home messages from the overall review, we highlighted that CCD was perceived as a framework and not an intervention. And this was great from informants' perspectives, because it facilitated an adaptation to different contexts and meant there was a flexible program that could be used by anyone. But the downside of this is that this lack of structure made it hard to implement. If somebody who has very little understanding of early childhood development picks up this program, not having information around how they're supposed to train individuals, what supervising and monitoring should look like, can make it a lot harder to implement. We also found that there was a spectrum of the extent to which a given intervention incorporates CCD, so going from that CCD based to CCD informed. And this is important to note because it really underscores the extent to which we can say that CCD is what's leading to changes that we're seeing in terms of child and caregiver outcomes. It depends, for a specific program, it depends whether it is only CCD or if it's CCD mixed with something else. When we talk about key ingredients, it's important to highlight what these key ingredients are so that we can better understand what is that kernel that is actually needed in a service to ensure that we're seeing the outcomes that we desire. And I think the biggest of these take-home messages, at least for me, was the need for more information on implementation. We just need to know how people are being trained, how efficient the training is, how they're being supervised, how we can better support and monitor them. And there was just very little data in this across all reports. And so that's really an area where we need a lot more information. And then finally, there's also a need for more information on the impact of CCD. And here we're talking really about CCD-based services. If we put that to the test of an RCT, are we seeing improvements in ECD outcomes and in caregiver outcomes? And then finally, I want to end with talking about some broader lessons learned, not just in terms of CCD's implementation, but also when we talk about parenting programs more broadly. The first thing is really ensuring that we're supporting delivery agents or frontline workers to deliver these programs. So this consists of really better understanding what the existing roles are of these individuals and how the program can be successfully integrated into it without overburdening them, without leading to high turnover rates, or without distracting from their current roles. So really trying to understand how best we can support and fit these programs into their existing services. And in order to do this, we need more robust training and supervisory mechanisms. It's also important to identify the key behavior change techniques that we need to ensure that interventions lead to better outcomes. And this really comes down to ensuring that we have a clear theory of change that outlines the different targets through which the intervention can lead to better outcomes. And finally, the importance of ensuring that we have vertical integration of these services. So ensuring that we're not just focusing on frontline workers, but we're focusing on the systems within which they work in order to facilitate the integration process. I'd like to acknowledge and thank individuals at UNICEF headquarters and WHO headquarters for their support, as well as my co-authors. I thank you for your time, and I'm happy to answer any questions.
So great work. I think more and more we're gonna keep needing those reviews as we have more of those programs being delivered. I wonder what was the most common delivery agent, because you listed a few, but what was the most common? And based on the numbers that you had, I don't think you had any clue of which one delivered better, but what was the most common one?
I would think community health workers, and that varied between community health workers who are volunteers and sort of, researchers came in and paid them a stipend versus community health workers who are actually paid by the health system to deliver the program. Yeah, and in terms of which one did the best job, yeah.
Thank you.
Yes.
This is terrific. I mean, you did a really great job presenting a lot of complex information and I think really thorough discussion of implementation. I guess I wonder, you mentioned understanding more about how these programs are implemented and how effective they are. Maybe you can say more about what you think the barriers are in that sort of actual behavior change, because the program itself is sort of counseling and explaining to parents why this is important. But in order for the impacts to happen, parents have to play
Right.
and do all these things that take time. And even for parents and the health workers both, it may be a kind of very radically different way of thinking about what it's like to interact with kids and what kids need, and takes a lot of time. And sometimes you don't want to play. Let me tell you. I don't know if you can sort of say a little bit about what you think the barriers are from sort of I think you really focus in a nice way on what the elements are, and you can imagine sort of assessing the frontline workers who are doing this and some of them being really knowledgeable, but that might be totally orthogonal to ones that are really good at playing with kids, right, and very inspirational and there's a transformational experience of seeing someone get on the floor and play with your kids and seem to enjoy it, and your kids seem to react really well, versus somebody who knows the tools, is a health worker and they know the tools and they're really good at taking tests and learning things. And I don't know, that's not a fully formed question, but maybe you can say something about what data you'd love to see collected that would say more about some of those more challenging barriers to sort of having this be, implemented and successful.
Yeah, that's a really great question. And I feel that there are two levels to it. So one is the behavior change techniques that the frontline workers are using in terms of how best to communicate with caregivers, but then also as a caregiver who's busy and has all these other things to do to then actually implement those lessons. On the first end, I think that it really comes down to having the right theory of change in mind in terms of behavior change techniques. And so Aisha and Francis Aboud at McGill did a review 7 or so years ago where they looked at different behavior change techniques. So if we focus on social support, having group sessions where you have caregivers from a community come together and play with children of different ages, and how that facilitates behavior change for the caregivers. We looked at problem solving. So not just telling them what to do, but then sitting down and thinking with them, well, why aren't, what are some difficulties that could show up when you try to do this? And a parent says, well, I'm at the farm all day, I don't know how to do this. And someone says, well, when I'm at the farm, this is how I do it. And they have that problem solving together. And I think that's a key behavior change technique that we don't see a lot in interventions, right? It's all well enough to tell people to do things, but if you don't sit with them to try to think, well, how can I do this given the circumstances I'm in, given the difficulties that I might be experiencing, then it's a lot harder for them to be motivated to change it. So I think really trying to enumerate clearly what are the behavior change techniques I want to focus on. And I think this is where public health can learn a little bit from psychology and looking at these different approaches of how to get people to change their behavior. I think that can make a really big difference in improving how delivery agents are then implementing the program. And in terms of the parent perspective, I think two key important aspects are that social support, just in terms of knowing that there are others around you going through with you. And I think the second piece is expanding our focus to not just think of moms as the primary caregivers, right? It cannot be just one person's responsibility to spend all day with the kid. Depending on the context you're in, you have older siblings that tend to do a lot, fathers, grandparents, cousins. And so this is an aspect that I think in the parenting literature we're oddly enough only now realizing, and just trying to think of, well, how do we go beyond one primary caregiver to think of broader societal change in terms of who spends time with the child and how they engage with the child. I don't know if that answered
That's
all of your
great, definitely,
questions.
yes, it does, and you even formulated it more as a question. Jackie, I see, has her hand up.
Yes, thank you. I'm sorry I'm not in the room with you, but that was a fascinating presentation. I have two questions which are related. One is, I didn't hear anything about corporal punishment and, you know, violence against children, which of course is a huge health issue from infancy onwards. So, you know, to what extent did you come across any data on that? And if so, you know, how robust was it? Because I think that it would be very surprising and sad if UNICEF left out, you know, one of the key human rights principles about, you know, protecting children from violence from this this exercise. And related to that, you know, norm change is always hard, as you were just saying. You need a support system, and particularly where you have entrenched norms which are socially prescribed or supported, and, you know, probably embedded in multi-generational families and so on. It's hard for young parents to change behaviors, for example, to do with corporal punishment and smacking their children or whatever. So I was surprised that you said that many of the trainings last like 2 days, maybe 2 to 5 days. You said sometimes the maximum 3 weeks. I mean, all the evidence, for example, on overcoming implicit bias shows that one-off or 1 or 2 trainings achieve very little. They have very short-term impact. What you really need is, I mean, if you're really trying to change implicit or embedded norms, which is what this is all about, you need a much more sustained engagement. It's barely worth doing something which is kind of so short. So I wondered to what extent you found evidence that this was also, I mean, you talked about the lack of evidence of implementation, but I think that, you know, you can assume that if most of the trainings and the most of the engagement is so short, such short duration, the impact and the enduring impact is going to be very limited. So I just wondered what your thoughts were on those two questions. Thank you.
Thank you for those questions. So if I remember correctly, the first one is about discipline and corporal punishment. So in CCD, there aren't any prescriptive guidelines around discipline and corporal punishment. If I remember correctly, there is information around the importance of loving and respecting your children, but it's not phrased specifically in the terms of don't, you know, beat your child. I think part of that reasoning is because it's targeted towards 0 to 5, the assumption is caregivers are likely to engage in corporal punishment at that particular age, and so there isn't that information. But in terms of the data in our programs, there were some programs that added that. So when we talked about adaptation and additional content that was added, there were some programs that added that additional information because they felt, you know, rightly as you're saying, that information needed to be strengthened. But within the CCD package in and of itself, there isn't data on that. But as of course, as you know, we do know that corporal punishment does lead to poorer ECD outcomes, and then interventions that try to address corporal punishment. You know, there's a lot of great work being done in Colombia, for example, on that in the Apapacho intervention with Jorge Cuartas, where they're really trying to look at, even at a national level, how can we change norms? How can we change ideas and attitudes around how ways in which it's okay and not okay to interact with a child, and particularly around corporal punishment, as a way of minimizing it in order to improve ECD. I'm now blanking on your second question.
My second question was, how long do these interventions last, and what's the point of just having 2 sessions when you're trying to do something as profound as change child rearing norms?
Yes, that is a great question. And so it really depends on the program in terms of how long the training, excuse me, the initial training lasts. But I think what's really key is having refresher sessions. So throughout the implementation of, in addition to having, for example, a week long, I think, so we actually recently did a implementation review on broader parenting programs, and we were finding that most interventions tend to have a week-long training, and those tend to be effective. But I think in addition to having that initial training, we need to have refreshers, we need to have boosters, because as time goes on, people forget things, not necessarily because they want to, but because they're busy, things happen. And so having that consistent support, and I think this is where supervision also comes in, where it's not a formal training mechanism, but it's a way of ensuring that the delivery agent has somebody they can talk to, somebody who can support them at the work that they're doing, so that it's not really just a one and done thing and then you're sent off to do this work for the next 5 months completely on your own. Yes.
2 questions. Excellent presentation, excellent work. One is on the content of the CCD. We do know the CCD has been there for a very long time, and the nurturing care framework was actually developed later on, at least refined later on. Looking at it from now, especially in view of your evaluation, are there any changes that you feel need to be done in CCD to make it more effective and also more feasible, and in some way more in line with the nurturing care framework, which has perhaps a kind of broader view of the whole thing? And my second question is, having come so far with the evaluation, and I'm just assuming, suppose somebody gives $5 million for a more systematic and prospective evaluation of this intervention, what would you think about? If suppose WHO and UNICEF ask for advice, what would we do with this money? What would you give?
So in terms of your first question around content and additional content that would be included in CCD. So when we were doing the review, we had some great discussions around the balance between including as much information as possible within CCD in and of itself, making it sort of a one-stop shop to address all aspects of the nurturing care framework, versus ensuring that CCD complements other programs that do address those other aspects. So if we think of parental mental health, for example, which is my area of interest, CCD has nothing on that at all. But UNICEF just released the Caring for Caregiver package, which does address parental mental health. So UNICEF's pushback to us was, well, we don't need to talk about mental health in CCD because it's in CFC, and if they're being implemented in line, well, that's okay. I think I don't know if I fully agree with that. And I think part of the issue is trying to think of, who are we considering to deliver this? Are we strictly looking for something where, you know, parents will be coming into the health service anyways, and so let's train a nurse, a clinician, a technician to include a few extra messages? Or are we saying that we're going to hire a completely new and independent person whose sole job it is going to be to improve ECD? And I think answering that question really helps us to decide how we want the package to be framed, because you're right, CCD doesn't address all aspects of the nurture care framework, but to have one individual do that on top of whatever their other roles are, that's a lot of work. That's a lot of burden to put on one individual who might see a parent for 10 minutes every other month. Do we really expect there to be a lot of change based on just those little contacts? I'm not so sure. On the other hand, though, if we're then combining those 10-minute contacts with media campaigns, for example, so ensuring that there's some level in which the population as a whole is hearing these different messages of the importance of playing with kids, the importance of caring for your own mental health as caregivers, then there might be a possibility where through having sort of one person who's given one package to talk about all these different aspects, in addition to this media program, that could then help to better ensure that we're improving ECD and ensuring that caregivers, whoever they may be, are as exposed as much as possible to these different messages. And I think that media campaign aspect is also something that we haven't really considered in terms of their ability to change norms. We had this conversation at the Society for Research and Child Development last month, where when we look at a lot of health interventions, for example, so I grew up in Ghana, I can still sing to you the songs that would play on TV about the importance of using a condom or having an insecticide-treated net. You know, there would be little TV shows, snippets, something on the radio. It was everywhere. And then that's what stayed with people and helped to change national ideas around, well, what's a safe way to engage in sex? What's a safe way to protect yourself from malaria? But in terms of ECD, we don't have that piece. And so you can train as many parents as you want to change their behavior, but then if all the other people involved in childcare don't think they should be doing that, makes it a little bit harder to see those outcomes over time. So then to respond to your second question about if UNICEF had $5 million to do a prospective evaluation, what I think they would do, there are different levels to it. So the first would be ensuring a more structured curriculum for CCD, because even though the flexibility is a great approach, I think it makes it that much harder for individuals who know nothing about ECD to then take it and implement it properly. I think there's also a need to have more structured manuals around how to train individuals, how to supervise them, how to consistently monitor the program. And then the last piece would be ensuring that we're able to conduct RCTs in different contexts. But I think that the support for implementation is something that they really need to invest in to ensure that the next 10 years of CCD look better than the last 10 years.
Thank you.
Anyone else have a question they want to ask? All right, well, that was terrific. Thank you so much for joining.
I thought she was gonna tell you 5 minutes.